Hi there, everyone. Good evening and a very warm welcome. My name's Lara, and I'm the chair of the AACBT eBranch Committee. It's so lovely to see so many of you join us for our first event of 2026 and the first session for our Advanced CBT Masterclass series that Chris is presenting for us, which we're thrilled to have. For those of you who might be new to AACBT events, or the eBranch at least, the eBranch is our online branch or professional development arm for AACBT. So our aim is to make high quality CBT training accessible to clinicians across Australia and beyond. And to create opportunities for practitioners to connect, share ideas, and continuing developing our CBT skills. So I'm joined tonight by my co-host Madeline Bisbee, who some of you might know as well. So Maddie and I are thrilled to be organising this masterclass series with Chris. So tonight is the first session of our Advanced CBT Skills Masterclass series, which has been, I suppose, initiated and developed in response to clinicians wanting more practical, clinically focused training around some of the, the very real challenges that can arise in CBT practice, whether we're beginner or advanced practitioners. So across the eight session series, we will be exploring topics such as case formulation, working with therapy drift, managing therapist burnout, and really strengthening those core skills that underpin effective CBT. So it's my pleasure to introduce our presenter for all 8 of our sessions, Dr. Chris Basten. Chris is a clinical psychologist with particular interests in health psychology and eating disorders. He's done his Masters of Clin Psych and his PhD at the University of Sydney, spent 15 years working in Westmead Hospital in consultation liaison psychiatry and the eating disorders units. He's held teaching roles at UTS and UNSW and now focused on private practice and training health professionals. He's also the author of The Art of CBT and has presented research at conferences and contributed to peer-reviewed publications. He's been a really important part of AACBT across many years now. He's been my colleague and mentor and therapy hero for about 25 years, and I've personally have learned an awful lot from Chris. Chris is very well known for his ability to translate CBT principles into really clear, practical strategies that clinicians can apply in their work. And we're so delighted to have him leading this masterclass series. So without any further delay, please join me in welcoming Dr. Chris Basten. I know it's not really like that we can do a round of applause online, but I'm sure, Chris, you can just imagine that we're all giving you a big round of applause. So I'll be handing over to Chris now. As we go through, if you do have any questions, please pop them into the chat. I'll be monitoring that chat and asking Chris questions as we go through. And we will also have a good amount of time for some questions and answers at the end. So without further ado, I'll hand over to you, Chris. Thank you so much.
Thank you for just this really exciting opportunity. I love what AACBT strives to do and succeeds at doing in terms of offering really good PD, and I'm a consumer quite often of the conferences and the Sydney events and things like that. So I'm grateful to the AACBT on behalf of the AACBT and the online learning committee, Maddie and Lara. I begin by acknowledging the Aboriginal and Torres Strait Islander peoples as the First Nations and the traditional owners and custodians of the lands and the waters that we're all on now, known as Australia. And in my case, I want to acknowledge the Darug people of the Eora Nation, given where I am this evening, as the custodians of the land where I am, and we pay respects to elders past and present. Um, I'm really excited to be here, and hope to see some of your faces and names um, over the next few months, actually. Um, it made sense to start with this particular topic on individual case formulation in complex cases for a few reasons, which I'll enumerate in a minute. Um, it's something that we all learn at uni. The universities tend to teach it really quite well. There are whole books devoted to it. So can it be taught in a brief little sort of skill level workshop? I think the challenge for me is to try to look at how we could do it slightly differently and to look at more complex cases. So I think there is definitely some room, even if we go back to basics, like Jacqueline Persons, Christine Podesky, oldies but goodies. So I'm digging deep to them. Janet uh, Beck, the whole Beck family have written usefully about this as well. So I'm coming from really from a CBT framework when we're talking about this. If you wish to, if you're working with schema modes, you would have a different schema mode formulation, perhaps. We're centering our focus on CBT. Where does this belong? Absolutely in the middle. The way I would view it is that what we're going to talk about over a number of these advanced level workshops are things like dealing with motivational enhancement. What do you do when a client just isn't ready to tackle the hard therapy that you know is going to get them better? And that's really common. So we're going to have a whole workshop devoted to that. And it ties in, it overlaps with your formulation and your ability to manage resistance. It will be presented in the formulation. So it's nice to do this first. Um, when clients get stuck, the more complex people, we require the therapeutic relationship. As you'll learn tonight, the formulation, when it's done well, strengthens, it deepens, it gets you on the right footing with the therapeutic relationship in the first place. If we're going to ask clients to do powerful behavioral experiments that actually really change their emotion and get them to shift their beliefs that they're stuck with, we might have to be creative. The exact behavioral experiment that we do will depend on the formulation. It also means that you've got to have the right therapeutic relationship, obviously, otherwise they won't be willing to do it. And we'll be spending some time talking about how to get at the right level of cognition, and that might pop up in the formulation. So these are the different topics that will be covered when dealing with complex presentations, comorbidity, when we get a bit stuck. And so, yeah, the formulation is at the beginning and at the center. So it's a great place for us to start. If we were all in the room together and you weren't muted, I would be asking you, how do you do your individual case formulations? To what degree do you do them in a written form? Do you write to your clients? Do you do a sketch? Do you do both? Do you have a favorite template? Or maybe you've got a few templates and you can pick between them. We'll be thinking through the strengths of using those templates and their possible downsides. You know the templates I'm talking about, like the 5 Ps is a great way to think about our clients, and I'll get onto that in a minute. And if you're not familiar with them, you probably are, but we'll have a quick look at the hot cross bun and the vicious flower. But why would one be taught or used over the others if we're going to use templates? I think I used like a version of the 5 Ps for years. Why? I don't know if it was because it was superior. It was just because that's what my lecturers and supervisors advocated when I was a student. And so I sort of stuck with that. Um, later on, came across the hot cross bun and thought, I don't really like that. It doesn't work for me, probably because I was trained in the 5 Ps. Um, and we'll explain the vicious flower because that's rather popular in the UK, a little bit like psychodynamic and psychoanalytic therapies sort of used more than anywhere else in France and other countries. It's got a cultural background. Anyway, I think that's why some are used more than others in different areas. So our 5 Ps, you know them. It starts with the presenting issues, and we want to think about um, what are the predisposing factors or the vulnerability factors. The problem with using the term vulnerability factors is it doesn't start with a P. It's got to start with a P, right? Then there's protective factors. Some people call them strengths. There's going to be triggers or precipitating factors, and of course the perpetuating factors, which is what we all formulate around, because a big part of CBT really is undoing or severing the self-maintenance of maintenance cycles or perpetuating factors. So I think most people would be familiar with that. Here's an example of a hot cross bun. It's really just more of a psychoed tool, but a lot of people use it as their principal formulation sketch. They'll be like, I can fit everything into this. Just about, I could take any client and kind of have my 4 boxes of, thoughts, emotions, behavior, and bodily sensations, and then explain how they're probably all connected. And when I've read a bit about the hot cross bun, they say all of the arrows are bidirectional and they're all connected. So it's a very inflexible version, which is why I think I don't like it all that much myself. But can be useful if you wanted to just help a client to kind of go, this is what we'll be focused on. And the reason that you're feeling this way and behaving this way is probably because you've got thoughts. So you could be presenting the cognitive model to them neatly like that. The vicious flower is where the idea is that the perpetuating factors are always the petals. This is a fairly classic one. It's sort of one of the evidence-based treatments for anorexia nervosa, developed by Janet Treasure's team at King's College in London. And they've got this sort of down the bottom, you've got strengths, you've got personality traits, sort of these predisposing factors down the bottom here, the presenting issue in the middle, and all of the maintaining factors around. And it's an evidence-based model. It's quite prescriptive. They would say it's part of a treatment manual, and they would say to the therapist and the client, you need to fill out these boxes here. And so there's nowhere to add other things. And if it doesn't fit, you go, I don't know what to put there. So one of the strengths of having a template is it makes you go, oh yeah, I should really think about something like, cognitive style. I've got to remember who's around them, how people close to you are actually influencing you. I didn't think of that. So we get prompts and reminders and boxes to fill in when we've got a template. And therefore that can be helpful. So, I think the strengths of if we're doing an individual case formulation include that it's from a learning point of view. I think it's a great starting point, and it reminds us what ought to go into a typical individual case formulation, and it gives us structure in the face of complexity. And that anxiety that we get never goes away, I'm sorry. And so we always love structure and, something to go back to, some principles to go back to when we're sort of anxious and like going, oh, what do I do with this person? I'm going to recommend this evening that you are inspired by your favorite templates and for a little while stop using them though, because of potential weaknesses. And you can always go back to them, and I would say retreat back to that if it just makes sense, if it absolutely works for your client. But there'll be a few that it might not work for. So this evening we're going to look at deliberately branching out, But I'm not dogmatic about it because there's many things that work and templates certainly have a place. And it's a great starting point.
Chris,
Um,
can I just interrupt there? So we haven't had any questions come
yeah,
through just yet, but I have one question or more of a just a reassurance checking thing for myself. When I'm teaching my students about formulation, we do look at the 5 Ps and then like say the Beck model for the
yeah,
formulation. I won't take the hot cross bun as a formulation. For me, that's just a way of capturing the sort of the CBT experience. And I say to my students that like the hot cross bun is actually just the presenting problem. So it's just that middle one of the
nice.
5 Ps. Am I misunderstanding that, or is that sort of fair enough? So I say the hot cross bun model just captures their actual presentation, but it doesn't tell me anything about, the precipitants or sort of the predisposing factors or the
Yeah,
maintaining factors.
that's a great way to put it. I agree completely.
Thank you.
In other words, it's sort of what I'll be using the language later of you can have a micro um, formulation and you can have a macro. So this
Yeah,
would be an example of a micro where you really want to hone in deliberately and go, let's just expand this little bit. And we'll have a narrow focus deliberately so that you can understand what's going on here.
yeah,
But then we need to think about, well, where did that come from and what else is sitting alongside it? How does it all maintain each other? And then we would view that as a macro. And you'll have two sketches.
yeah.
So one good guideline would be that you have as many sketched ICFs as you want.
Yeah.
Thank you. Good clarity. Yes.
And Chris, a question has just come through from Carolina. She's asked if there's any resource you suggest to use as a reference for the 5 Ps.
I think
Just the
Tedeschi
Tedeschi.
does talk about
Yeah.
it. Yeah.
Okay, great. Thank you.
Um, thanks. That was a really good question. Keep them coming. So let's really think about the purpose of an individual case formulation. I think it's pretty clear, but I want it to be defined. I would state that it's to develop and then share with your client an agreed understanding of the presenting problem or problems. How many of your clients just have one presenting problem? Comorbidity is the norm, isn't it? um, yeah, including what they wish to change, so the presenting issue, how the problem's developed, and why it's proved so hard for them just to change things on their own. If somebody's coming to see you, it means they've crossed that threshold into, okay, I can't do this on my own. I need to go out of my way to seek some professional help. And as we know, some people, their threshold is very high and they won't come unless things are proving really hard for them. If you like, some kind of some sub goals when we're working on that. We want to also, while we're developing and sharing that understanding, we want to be able to show, I want to be able to show that I've been listening, actively listening, trying to understand. I'm going to say, look, I get this. This is you. I'm not going, oh yeah, look, everybody who gets depressed, they all have, problems in this domain of their life. Or something like that. Not that you do that, but I think some clients might perceive it that way. Anybody that has panic attacks, it's just misinterpretation of benign physical symptoms. Look, I'll show you this model. We want to be able to lean in and go, no, 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 like I've been listening, and this is what I think is going on for you. It's great for that alliance, and then they'll listen to everything else that you want to say downstream from that. I want to say to them, I think this makes sense. It makes sense that it developed and then it got stronger, and then your efforts to try to manage it, it makes sense that wouldn't work for these reasons. And so I'm conveying to them like there's no negative judgment from me, and at the same time, equally modeling self-compassion for them and maybe developing self-compassion. And we know that that helps with behavior change and cognitive change. And some clients need that more than anything. And of course, these last two bits, there's hope, I can see a way through, and certain interventions are going to make sense. Some will be necessary. which brings us to this idea of this critical idea with the individual case formulation. It also establishes a rationale for treatment. It could be a trigger for psychoeducation. And it's a vehicle for the psychoed. You actually start doing it in your formulation. And as we know, it demonstrates links, how several issues that are occurring at the same time can be connected, and how current coping strategies are actually maintaining factors. And therefore, the disruption of that, is the rationale for treatment. And it's a reference point to keep coming back to. We've already talked about self-compassion. And this idea of decentering, one of the lovely things about a good individual case formulation sketch, and why I think a little sketch is sometimes superior to a written formulation, which might be in greater detail and more sophisticated, and you can put a lot more into like a 1.5-page written formulation. But it's just a quick reference that you've got on in the file or on the desk, and you can pull it out. And a picture says 1,000 words, and a client can sit there with you and go, "Oh yeah, right. Yes, 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 that's right. I can kind of see that now." So it creates they're not stuck in it. From the client's point of view, we want them to be able to think, "Oh yeah, right. I can see how that's actually relevant to me. It's nice that I get to have a say. I get to put in stuff. You're even using my words, my language, and so it's easy for me to understand. But you're also making connections that I couldn't see before. And now I can see what I can see what I have to do in order to feel and function better." And of course, if they don't, then there's no point proceeding, because you have to have agreement on what is the nature of the problem, what are the maintaining factors, what treatment makes sense, to actually have a client in the room that you can work with. Which are really useful questions. Can I check in to see if there's any questions in the chat or even coming up for you right now?
Nothing more. So just a question about getting your presentation. Nothing else at the moment. Doing great. Thank you.
I can send the slides. I've got a PDF version of the slides, which I can send. So
yeah, no, PP's already answered that. All good.
Yeah, good.
Yeah. But I have to say, I find that clients are, like, they love hearing their formulation. Like, it seems to be just, one of the most validating things for them, and really sort of serves to engage clients. It's kind of like there's all this assessment, information, and they might be presenting in chaos, and our formulation is always, I always think of it as, we just organize it all and tie it up neatly with a bow and give it back to them, and they go, "Oh, that's wonderful."
Yep. When done well, if you have that experience, it means you're doing it well. Yeah. Which is a good sign. It's a good sign. To be honest, I have not done it well sometimes. I'll do that up. I'll wrap it up in a bow.
None of us do it well all the time.
And I'll get, all right, I get it. So basically, I've just been a friggin' idiot. I'm like, whoa, okay. Now that's not the client's fault entirely. They've probably got a defective schema, and they've probably got a vicious self-critic, right? We know that. But then I think that's a message for me that says, okay, well, okay, I could have probably delivered that better, and I probably should have tuned into that. But if it's just really early, then I'm going to have some self-compassion for me too, and go, that's all right. You can't read your client at the end of session 1 all the time perfectly well, but that's more data, and I might correct them straight away, but also go, wow, do you do that a lot? Where would we put that in this diagram? It's kind of like, like a little bit of something happens and your mind reacts to that, because the brain is just a stimulus response machine, right? There's a stimulus, the brain responds, or our cognition responds with, "Oh, so I'm an idiot." Anyway, we can whack that into the formulation.
And Chris, Michelle has just asked, after how many sessions would the case formulation be presented?
That's a great question. You know the answer, Michelle. It depends. So it depends on the complexity and how you prefer to work. I reckon aim to do it around at the end, or maybe even halfway through session 2, like at the end of your assessment. Would it be premature to do it at the end of session 1? Only if you're the sort of person that leaves 90 minutes for an assessment and it's a relatively simple presentation, you could probably do it at the end of session 1. And if you find yourself not doing it till session 3, no big deal. But I reckon the earlier the better in a way, and even if it's just part of a formulation, because a good formulation evolves over time. You get what you've got, and then you add more detail later, which I'll demonstrate with an example where I don't know exactly what's going on at all, and I get more information, and so we just add to the formulation. My formulations are rough and imperfect, and they're quite organic, but they serve a purpose. We know what we know. We listed those sub goals, and as long as I think if they're meeting those goals, then I need to just abandon my personal desire for symmetry, neatness, and no spelling errors. But that's very rare. It's just messy and it's just a bit, you know. Anyway, so we've listed the goals. The question is, can a standard template serve those sort of functions? And
Sorry, Chris, Nicola's just commented that she only gets 6 sessions with patients and worries that she can't cover everything in the formulation, and is just asking, should she get the patient to prioritize what they want to work on?
wow, yes, they should. And I reckon the formulation would probably help that, wouldn't it?
Yeah.
You can kind of look at it together and go, wow, there's a lot going on, and this is really long term. And that wouldn't, in my experience, that wouldn't be undone in 4 sessions roughly, because we're going to do an assessment. We'll have 4 sessions, and then we need to sort of think about relapse prevention and setting you up to move on. Let's look at what makes sense to work on. I don't know, it's not just the formulation, but I'll talk about it anyway. What makes sense is you always go with safety first, and then you go with client's preference, but that might be trumped by a third factor, which is what makes sense in terms of sequencing according to the formulation. So, somebody might say, I don't want to work on that at all, but this is my goal. And you might just think, I can't agree with that. The behavior that you're doing is really unsafe. I just wouldn't do that. Or you might just think, well, that'd be great, but you won't succeed until we've dealt with this coping behavior, because that level of avoidance is going to stop you from getting better. And that rationale becomes clear in the formulation. But we should always be asking the client what it's their therapy. They've got to say what they want to change. And if we want to disagree with them, or put forward say, I want to help you with that, I think we're going to have to do this first in order to get there. Then the formulation helps to justify that process, doesn't it? So a template might be sometimes too limited when there are multiple presenting conditions and they impact each other and may have contributing factors in common. So somebody's got a classic example, right? We know comorbidity in an anxiety disorder. Somebody presents with an anxiety disorder. You're going to go looking for substance use because they might be self-medicating. And you're going to go checking for mood because they might be quite down and depressed. Somebody with PTSD or trauma, they're probably going to have the same comorbidities. With an eating disorder, you have multiple comorbidities. And they often do come from the same place. If somebody's got more than one, somebody's got GAD and illness anxiety, and some OCD, you're like, well, that's not that uncommon. Combined, it's sort of like united by an intolerance of uncertainty and probably other obsessive compulsive cognitive traits. And you think, well, for the middle P, what do I write? Do I have 3 different templates, or do I put all of them down? I would probably want to put all of them down because they've got like a common contributing factor, or they're tied in with each other. So you kind of want them on the same page. Let's go this way. The presentation might be a bit atypical or something where, there's when we get trained in CBT, it's often by diagnosis, isn't it? There's a treatment manual for social anxiety, for panic disorder, for GAD, for health anxiety, for BDD, for depression. And then you go, well, hang on a minute, what do you do when somebody's got sort of maybe this, it's really disruptive to their functioning, but it's not really a diagnosable condition. And it might be a bit outside the box. You want to be able to go, that's okay, I can formulate it. I'll just start with the presenting issue and we'll go from there. I don't have to work out which box things go in. Um, or the client is ambivalent, and that's okay. Most clients are ambivalent, and it can fit into like something like the 5 Ps. Um, by all means, or you can just ignore it. Or you could add it in as an extra factor. So that can be okay. Or down here, there is a particular contributing factor that you really want to highlight, because you've kind of figured, okay, I think this is the critical maintaining factor. It could be like neurotype. So they might actually be on the autistic spectrum. Cognitive style, incredibly rigid, all or nothing. So maybe a bit like autism, but more just like an obsessive compulsive personality trait, or it could be a schema. I mean, the one time I did it again with one particular focus was because somebody just was ruminating all the time and overthinking, and we really just wanted to do a formulation around that. So it was half formulation, half psychoed tool, but there was not much else to formulate around. And the overthinking was leading to, like depression and sleep disturbance, and self-criticism and relational problems, because they'd rehash conversations that they had and then ask somebody, well, why did you say that? I need to understand why you said that. And everybody was like, you're too hard. So that was just a unique formulation in a way. And finally, maybe the symptoms can become the actual symptoms become self-maintaining rather than, say, a coping behavior. And this is classically done in depression, isn't it? Where, so the symptoms of depression part of the presenting problem, or is it in the perpetuating factors box? Let's have a look. I'll show you what I mean. So my starting point when I said, okay, I think you've developed depression. My assessment's leading to that conclusion. So of course you're going to have depressive symptoms. And we're really interested in what those vulnerability factors were, what might have made you vulnerable to developing that. There were a number of multiple stressors that would probably get anybody a bit down as well. And then what happens is you end up with low energy, low motivation. You can't enjoy things. You want to sort of back away. You say no to things. Your sleep's disturbed. You're irritable. If you're doing less, you've got more time to ruminate about your depression. And of course, this big cognitive triad of negative thinking about the self, future, and the world around you. You might also have some cognitive symptoms like your brain is slowed down. You're not thinking as sharply and things like that. So, this looks more like a psychoed tool, doesn't it, than a formulation, but it's actually the start of a formulation, as well. And I think if we're trying to go, hang on a minute, I need to think about which box it's in. There's a couple of things that go wrong. One is, that I find a bit unhelpful anyway, is that I'm free just to draw the arrows in wherever I want. And on this example where the symptoms that are part of the presenting problem can be very self-maintaining, especially with, I might blow this one up here, the negative thinking into the depression, and turn that into a hot cross bun micro formulation and go, let's just look at that. And then you get up in the morning and you feel the physical symptoms are you feel dreadful. And then you think, oh, this is going to be a bad day. I don't think I'll go to work. And we'll just do a little analysis of the cognition and the self-focus on physiology, and zoom into that as a micro, and then zoom back out and think, let's just think about the bigger picture. Does it tick some boxes? in terms of will the client go, oh, right, I didn't know all of that. I didn't understand that was all depression. Now I can see that, yes, right. When I feel like the right thing to do is to stay at home because I feel so bad, but actually what you're saying is that's going to make me feel worse. Um, yeah, I don't think I can change my thinking. Can anybody change their thinking, really? Well, do some work around that. Any questions about that?
Yeah, Peter's asked a great question. What are your thoughts about using AI, such as Heidi Health, to create a 5P formulation?
Um, I haven't got a lot of thoughts. I'm still trying to work out what I think about AI. Whenever I've used it a bit, I've always found it pretty helpful and powerful. Um, our practice policy, just where I work, is that we're not using any note taking yet. We haven't established that any of the offerings are safe enough. So that's a very cautious model. I know a lot of people are loving it. So you need to use it. So I'm a bit cautious about using Heidi actually in the first place. So because I haven't used it, then I don't, I think part of the answer is I don't really know. I reckon you just got to give it a go, right? And see what you think. And like a lot of AI, you do it with a skeptical eye going, that might be better than what I can do. It might be more efficient than what I can do. It might be inferior what I can do in terms because it might be missing things. It's just we're assuming that um, like a model like that can actually extract the most relevant data. And I think it'd be remarkable if it could do a better job than you, Peter.
Yeah, I find, I mean, I do know a lot of people who use it, and I know that it can be very, very helpful and powerful, as you say. My concern, Peter, is about, people then, especially when they're training, that they're not actually sort of, I suppose, internalizing these skills and creating the scaffolding for themselves if they're relying on AI. So I make sure with my students already when I have on placement that I will make them as an exercise just write out the formulation themselves. So before they have a chance to use any AI, so say after seeing a new client, so to actually handwrite or type the formulation without using anything, just to make sure that they can do it. And then I don't mind if they're checking it on AI and seeing if it, refines it or picks up anything else. But I just want to make sure that psychologists don't lose that ability to actually think it through, because I think case formulations are one of the things that really sets psychologists apart from a lot of other allied health professionals. Chris, we do have some more questions. Hal has asked, as individual case formulation is an ongoing process, do we present ICF to our client whenever it is updated or modified?
Yeah, for sure. I probably wouldn't modify it without them. I would do it in front of them,
Yeah, yeah,
with them. Yeah.
yeah. And
I'd be thinking
Louise,
about it in between sessions and go, oh, right. Okay, I'm going to add that to the formulation and I might even do a draft, but then I want them to see it. I want them to be a part of it. It should be collaborative. And they go, boom, yep.
And Louise has asked, just referring to the screen now, is this an example of the formulation you use when you're ditching the templates with clients, as in you use it with the client and in development?
Yes.
Yeah, fantastic. Michelle's just made the very helpful and accurate comment that AI misses the observations I make of the client and the connections that I make. I agree with that, Michelle, yeah. Jeremy has asked, is it best to organise our formulations around diagnoses or the core maintaining processes? It's a great question.
Yeah, I love that. I love that question. If I'm not sure, then I might try both. Like I will say to you several times this evening, have more than one sketch. And it's part of your overall formulation. This is the way I formulate my client. Like we've already said, you could have a micro and a macro. There could be a focus here and a focus there. But in the end, it depends on, I think, how the first one is. It depends on what I think the clinical priority is. And of those different goals that I was talking about, um, you know, which are the ones that I want to prioritize today. So if I really want to establish that certain interventions make sense of the rationale for the treatment, it might well be more on the maintaining factors that I think really need to the client to go, oh, right, okay. I thought what I was doing was okay, but it's actually keeping me stuck. And they'll be like a safety behavior, a reassurance seeking, not going somewhere with an anxiety disorder. So there might be a host of safety behaviors. They're like, well, it enables me to function. I can go out when I do that. But now you're telling me that it's maintaining my anxiety disorder. Oh, I kind of get it now. So that might be the focus for that particular picture, because I'm like going, I think this is the answer to your question, which is why are you not getting better? You should be, my client says, but exposure is supposed to work. I do it a lot, but I'm not getting, my anxiety doesn't go down at all. So you know what I'm going to put in the picture.
Yep. Okay. And Caitlin has asked or commented, I find it hard to deliver the formulation without writing the formulation down, simply because there is so much information and it is hard to convey all the links by just talking. How do you suggest presenting formulations without writing for clients who have limited literacy or otherwise have difficulties engaging with written language?
Oh, great question. The answer is I struggle to do that well. And when I've thought about it before, when I've been forced to think about it before, I will talk to them about it and try to use pictures as much as possible,
Yeah.
like icons even. And it's terrible because I'm such a bad drawer that I can't draw pictures very well. It's handy to be a good sketcher. But it's really good that you're even asking that question. It's a type of cultural awareness and sensitivity, isn't it? And we really need to think about that. One of the topics that I want to talk about, and one of these advanced skills, is also how people learn, because we do so much psychoed, even when we're not officially in psychoed mode. I feel like I'm not doing psychoed anymore. Now I'm starting cognitive therapy, but I have to teach cognitive therapy still. So we do a lot of teaching. Anyway, I found somebody to co-present with me who I've been picking her ideas because she was a teacher for years. And then she became a school counselor. And then pretty quickly she went, that's not what I wanted. Then she retrained as a clean psych. So we're going to talk about how people learn. Literacy overlaps with that. It's a bit different. But anyway, I think if you can sketch it using icons or images, that's one way around it. Yeah. And work it out with the client.
And then Louise has asked, do you ever use the 5 Ps and then when the goal or presenting problem is identified to work on, you progress to this diagram that you've got on screen now? So
That's a fantastic way to work it. Yeah.
I'm thinking of clients who have comorbid conditions and potentially the diagram could become really busy.
I love it. Yeah, I do. I think, especially if you're very familiar with the 5 Ps and you've learned that way, I would suggest, maybe even when not with the client, to sort your thinking out, put it all in your boxes, and you might have two of them for different presenting issues. Then when it comes to the actual session with the client, where you want to sort of focus in on some of the maintaining factors, or it's a selective thing. So a few of the questions have referred to this idea that there's just too much going on. How do you present it all in the one go? If you try to do that, it probably won't meet those goals. The client might feel overwhelmed or confused, and feel like they're just too unwell. So it needs to give hope and a sense of understanding. And I can see now, and I can see what treatment makes sense. So anyway, I think especially if there's a lot going on, feel free to start with your 5 Ps for sure, because it's a good way to think.
Great. That's it for now. Thank you, Chris.
Beautiful. So here's a few kind of, if you like, tips. It's really handy, isn't it, to know your theoretical models and try to recall them. But we wouldn't want to show that because that's just it's not really an individual case formulation. Um, uh, and we want to focus on the I in ICF. So the David Clarke's model of, misinterpretation of benign physical symptoms in a panic attack is an example of a model. I think this is Barlow's model of panic disorder. It's more of the macro. You've got an alarm reaction, there it is there, but you've got all these other factors going on. So you've got your catastrophic thoughts, running away and escaping. You've got hypervigilance, avoidance, and anticipatory anxiety, which is the defining feature of panic disorder. And then, of course, that just leads to an increase in anxiety symptoms and sensitivity and so forth. There's a good reason why we don't show these pictures to our clients is because it's not individual, and they might go, what's tachycardia? What's dyspnea? Oh my God, am I sick? So there's a whole bunch of reasons why you don't do that. Just make it individual. Here's an actual example then. So here's a good model. It's well supported empirically. Chris Fairbairn's formulation of bulimia nervosa, which starts with this central feature of overvaluing weight and shape in terms of a person's self-worth, leads to dieting and weight control behavior. And if you do that, you're probably going to end up binging because you're starving. And then you're going to end up with compensatory behaviors, which means you're going to binge more. And if you binge eat, you'll probably want to not eat. And it's pretty good. It helps explain a lot. We also know that some people binge eat because of negative moods. So completely different. You've got this restriction pathway and an emotional regulation pathway. And again, we don't want to show that. We want somebody to go, oh, right, you've been listening to me and what you're feeding back to me now makes sense. And I can see this in a different way and I can see what needs to change. So here's how one client looked. It was like she was trying to work out how to not binge. Very obsessional, rigid, perfectionistic person who we worked out just backwards. She was just getting really hungry a lot of the time. Where did that come from? Where did that come from? So she was losing weight. And she was able to articulate that, yeah, she just went, but it's just the whole way. I think ever since before I was in high school, I just remember thinking it was the most important thing to look pretty, to look petite, and everybody commented on it. So I was like, when you say everybody, where did that come from? So we looked at those messages. There was a feedback loop. So that's kind of how it looked. And by the way, the rule violation effect is that classic thing because she was so rigid and had dichotomous thinking a lot and a perfectionist. She was like, well, you need to have rules, right? And you have to follow rules, and you're either following them or completely breaking them. You're either on track or you're completely out of control. So if she ate something that was violating one of her rules, that's a rule violation effect, and she didn't end up binging. So we were able to look at all of these mechanisms that led to that. So that's kind of, like a real life version of a model. And the implication is you just got to eat and tolerate the risk of losing weight. Easy, right? No, that's okay though. We've already talked about this idea that you can have micro or macro formulations, and you can have as many as you need depending on the focus in treatment. Let's look at Amanda quickly. 25-year-old woman with, not too bad, but moderately severe panic disorder. After she experienced a few panic attacks. She does not respond quickly to psychoed. Some people get better. You explain that it can't hurt them. You look at the evidence. How many times have you felt anxious? How many times did your worst fears come true? Let me tell you a bit about the flight-fight response. If we think about it, imagine what would have happened to mankind if we all fainted and collapsed or went crazy or had heart attacks every time we got anxious. It doesn't make sense, does it? It's a survival response, not a catastrophic death response. Let's do a couple of little experiments, and some people get better quicker than others. She wasn't responding to that much at all. And an important contributor to this is her intolerance of uncertainty. She also scans her body many times a day looking for signs that anxiety is coming back. It could be a bad day for anxiety. Her physical health is bad. We can do an individual case formulation sketch just for the anxiety attacks, and then maybe a bit of a bigger one to encompass the panic disorder. So I'd start with, this version. I'm not happy with this because I've done it in PowerPoint. I really should just hand draw these things because it doesn't look like this doesn't look like my formulation at all, but I might use these words. And sometimes I do put question marks in. I'll be like, I'm not quite sure yet where that comes from. We're going to deal with that later. I'm going to ask you about that later. For now, I just really want to focus on this. So you've told me you get this ice cold rush. Is that right? And your mind goes blank. And then because your mind goes blank, you freak out about that. And you really hate the shaky and feeling and the way your heart feels funny. So I'm putting in the client's words. Of course, that's scary, isn't it? Right? So would it be, could we write it this way? Amanda, like that you kind of see that as dangerous, which activates your sense of threat. So then you get a fear response in your body. So what do you think, Amanda? Can you see how, it's the critical thing is whether these are dangerous, and we're like going, where does it start though? Where does this start? And then we want to look into that. With time, I kind of go, okay, we need to kind of look at what are your cognitive traits that might be meaning that you're more likely to interpret this as dangerous. And we're going to really focus in on your internal self-focus because you're examining yourself a lot. So we're going to add that. And so, wow, okay, I've learned now that you're very detail focused, um, uh, constantly looking at sort of the fine detail. And that's the way you are with everything, with work and with relationships, with your physical appearance and with your body. And you've got this high need for certainty and predictability in life. You're in a terrible job, but you wouldn't leave it because you just don't know whether the next job would be worse. It's hard for you to tolerate uncertainty anywhere. So that might explain things a bit. So we can put that in. And that would belong, if you're doing your 5Ps, that would just belong in a predisposing box, by the way. Like, that's just how your brain works. And this is the more macro one where we've got these are your worry thoughts, and we've got all of these different factors. You have had bad experiences with anxiety. It was terrible. You felt dreadful. And of course you don't want those bad feelings. That's normal. And so it would make sense that you're going to monitor your body and what happens when you monitor it, etc. I won't go through it because it's pretty boringly obvious. But so that's just like a big one. So I'm just saying these are two separate pages. So micro and macro. I think I've made that point satisfactorily. We're going to go on and do another case now, and then you'll actually see me do one with a pen just to kind of see it emerge organically in a minute. But just check in if there's any other questions.
Yeah, we've just got another couple. Thank you. So Charles has asked, hi Chris, do you have any advice and or tools for completing ICFs in a collaborative way via telehealth? I'm currently working in a setting where the majority of my caseload is seen remotely.
I've tried a couple of things. So it depends, of course, which platform you're using, and how good the whiteboard is on it, and how familiar you are with that tech.
He's using CoView.
CoView. Oh, right. I haven't used it, and I mean I've been on the other side of it. In supervision, when I get supervision, my supervisor uses CoView, but I can't remember. I think there's a whiteboard on that, isn't there? And he'll sketch things out and draw things. Zoom has a better one than Teams, I think. So anyway, that's an option. Because I found it hard to use a whiteboard, I get a clipboard and I do this.
Yeah, that's what I do.
And then I scan it and send it to them. Yeah, you do the same, Lara?
Yeah, yeah,
Yeah.
I'm old school like that.
I'm a bit embarrassed to say that's what I do, but I've tried different things. But yeah.
And Lisa has asked, do you have any suggestions for how to help identify and explain different cognitive styles, traits, and biases to clients? Lisa always asks the hard questions.
Well, it takes a while, doesn't it? Yeah. I think for a clinician, it's pattern recognition largely, isn't it? You hear one thing and you go, oh. like so this example that I've been banging on about a couple of times, like with the dichotomous thinking, I just hear somebody will just say one thing like, oh, no, no, I don't see her anymore. No, 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 she upset me once, and so she's not a good friend. And you're like, okay, you're probably going to do that across multiple domains where you're kind of, maybe intolerant of perfection, of imperfections in others, and all or nothing thinking. So you zoom in and you go looking for it. Or, and worry, if somebody's worrying, you kind of know that they've got intolerance of uncertainty. Um, uh, Another trait, one of those transdiagnostic traits that we want to look out for might be, um, there's perfectionism, but there's also, very self-focused, and then intolerance of distress. So depending on what, and they're sort of things that you study and you go, well, these are well-known, well-documented transdiagnostic factors. Other cognitive traits, they might be more vulnerability established from a schema, say, or a learned sort of core belief. And again, I think it's pattern recognition, or you could use like Young's schema questionnaire or something like that to go looking for this like strong magnet that just pulls everything in towards it. So if somebody kind of knows that they're completely unlovable as they are, because that's a fact, right? Um, Certainly manifests as that if it's a schema, then you'll start to see those cognitive traits in that area, which is more schema rather than neurotype. Because I would call something like, obsessive compulsive intolerance of uncertainty, even if they don't have OCD, but it's still kind of like that sort of brain type. I feel like I only half answered your question, Lisa, but it's pattern recognition, maybe use questionnaires and just go hunting, go ask them.
Great. Thank
Where,
you.
where you put that in a schema formulation is usually a bit like this. I might draw dotted arrows as well, going, it's not really a direct causal connection, but it influences everything. And I do have another couple of examples for you later.
Great. Thank you. And Lisa has said thanks.
Can I introduce you to G then? And I really want you to, we're gonna go through these are very word heavy, text heavy slides. But, if we were all in a room together, I'd probably give you 2 pages and we would read about G and then think about it. I dare you to grab a bit of paper and if you've got one, or you could use a notepad or whatever device to sort of think about how you would draw an individual case formulation sketch outside of the P's, where you would start with what is the presenting issue, or are there two presenting issues? Do I put them side by side, or do I put them on top of each other? And then you're listening out for triggers and perpetuating factors. It doesn't matter, they're going to be above. And then you're looking out for maintaining factors below. So really, I think you'll get more out of the formulation, this workshop, if you can just start sketching things roughly, because their first sketch is always really rough and kind of end up going, hang on a minute, that belongs there, not the way I drew it. Tolerate your imperfection. Yeah. Anyway, G is a 29-year-old cisgender male living on his own in rented accommodation since a flatmate moved out 2 months ago. A business studies graduate, he's working in project management in the city of Sydney. He recently saw a GP after having a severe panic attack at home. It should read at work. He had a panic attack at work, and the GP's assessment included that he probably had depression. Because if you've got a big K10 score, that's a diagnostic thing, isn't it? On assessment, G's not so sure about depression. He's like, yeah, the GP said she thought I had depression. He agrees he's been anxious recently. Now he's worried that he'll have another anxiety attack, so he's a bit nervous about going back to work. He said he's irritable and impatient. He feels stupid for making mistakes, and the problem is more that he's lazy than actually being depressed. The panic attack occurred at work as G was receiving negative feedback from his manager for arriving late repeatedly. He couldn't account for a recent sick day, and his productivity at work was low. And he's now worried he's going to lose his job. Other stressors include that he's paying all the rent on a 2-bedroom unit in Sydney. Who can afford that? As it felt too hard for him to place an ad and recruit somebody, and since his flatmate moved out. See what I mean? Lazy, but useless. Well, that's what G says. You ask about whether his productivity is indeed low, and if so, what might be leading to that? Because one of my hypotheses is productivity might be low, and if it's low, it could be because of depression. Maybe the GP's right. Maybe it's not low, and maybe you're an extreme perfectionist and you're judging yourself harshly. I don't know. I've got to ask. But we start hypothesizing, don't we? And I can't write anything down in the formulation until I know. G says that he's often bored at work, finds it hard to get complex tasks started. His concentration is even worse than ever in recent months. He said that he knows he's weak, pathetic, and lazy. You ask about sleep hygiene and health, and G shares that he stays up late most nights gaming with friends in multiplayer games. And this is the only thing that gives him pleasure. That and a little pot that he smokes most nights, which enhances his gaming fun and then helps him to sleep afterwards. So there's plenty of fodder for an individual case formulation, isn't there? You go through a more formal symptom checklist, and he says, yeah, I've been feeling miserable, got less enthusiasm and less enjoyment than usual, feel a bit dead inside. Increased worthless thoughts and feelings. He says, I've always been self-critical. I've got lots of reasons to be self-critical, but it's like now I just really feel really useless. He's been irritable and impatient, yelling at himself uncharacteristically when he makes a mistake. He does have increased anxiety and feelings of dread, especially going to work. His concentration is worse than usual. He agrees that energy and motivational levels are lower than usual, and he's finding it hard to get just tasks done, like placing an ad for a flatmate, things like that. Wasn't clear whether there was a sleep disturbance. He was like, "Oh, you haven't been sleeping well." I was like, "Is that different from normal?" He's like, "No, just always slept badly." So they couldn't tell that. He denied feeling hopeless. He denied suicidal ideation, that his appetite hadn't changed. Oh, where do you put all that in a formulation? I don't know. Do you put it all down? I'm not sure. There's no rights or wrongs. Here's some questions. Would you include the anxiety attack and the fear of panicking? Why would you do that? Why not? Like you could. Or where do you put the depression? I'm assuming he's got depression, right? Would you include the marijuana and gaming? And what would you emphasize at a very early stage? You don't have to do everything. There'll be other opportunities to do things. Let's have a go. The way I want to do this, I did store my videos here, but they don't really work. I have to stop sharing and open up. Sorry for this pause. So we've been talking for quite a while. Hang on a minute. I've got to share this now. Go to share. Sorry, I have to talk out loud, otherwise I can't do it. I go to share and then click on that. Done an incredibly good job. So we've been talking for quite a while. You've done an incredibly good job of trying to explain how you've been feeling, how you've been functioning, tolerating all my questions. I think we're at the point where we can do a summary. In fact, we should really try to tie things together, make a little summary of what we've got so far, what we've been talking about, and how things might make sense in terms of what leads to what, and also what intervention might make sense. You might also want to know,
more clearly what I'm thinking in terms of, is there a diagnosis? So far, because I've been talking about this a bit, I've been thinking that it's not so much that you're lazy or an idiot, to use your terms, but actually you've got a significant depression, which is a condition that anybody can get. And that comes along with, and this is not uncommon at all, with really strong negative thoughts, which is a bit of a vicious cycle in itself, because if depression makes us think more negatively, then our negative thoughts are going to make us more depressed, especially your worthlessness and your self-criticism, which you said you've always had, but that's really ramped up. Now, I've also shared with you some information about depression, but let's summarize it here again. It's not uncommon for somebody to have decreased motivation, decreased energy, and that just makes it really hard to do things. It's also not uncommon for somebody to have a bit of a crisis of confidence, and increased anxiety as well. So I'm putting that in the middle of things, to be honest. I think there's more to your depression than that, but let's start with that. And then, of course, that we've already said that makes it harder to get things done. We'll come back to that. That would make us understand then why you're more likely to game at night, and also why you're more likely to consume more pot overnight as well. And with all of that going on, just the decreased motivation and energy. Oh, the other thing that we really should add is that, like many other people, you've got decreased concentration, and problem solving. It's just really hard. So if your brain's not working well and your energy levels are low, then, and you're trying to cope with this in understandable ways, then you're going to get a lot less done. We might even write that down. Get less done. It would also explain why your productivity plus attendance at work has tanked. So let's draw some arrows in. So I've already drawn a couple in here. You're going to get less done because of all of that sort of stuff. And then your productivity is low. And I think what's become clear to us, I mentioned this before, but it goes in our summary, is
any questions so far? Hopefully it looks a bit different from yours. The reason I say that is because everybody's formulation should look a bit different. They're never going to look exactly the same. I love looking at other people's formulations because I keep learning. I was like, oh yeah, I wouldn't have thought of that way. That's good.
So Miles has just commented, that's brilliantly simple but really effective.
Oh, thanks. And I'm not going to lecture G yet. We might do it Socratically later with how his productivity at work might actually be seriously affected by his marijuana use. But I'm not sure. And he didn't come for a lecture about his marijuana use. So, but I did draw an arrow from there down. Anyway, we'll keep going.
that when you...
Oops. I was sharing the wrong one, wasn't I? Share. Is this the right one?
Your productivity is low at work, you find yourself being much more anxious. You find yourself having much more negative thoughts about yourself. And so the anxiety makes it hard to perform because you're sitting worrying about yourself, and the negative thoughts make you more depressed. So we can see that there's these feedback loops that are keeping you stuck, which is exactly why over time people's efforts usually, not only do they not work, they might even deepen or intensify depression. What do you reckon, Chi? Have you got any questions? What would we... It's looking like a bit of a mess, isn't it? But is there anything that kind of doesn't make sense? Try to make that clearer by doing it that way. We've got getting less done. If you've got any questions, tell me if there's anything that's not quite right. We'll change it. We can cross it out. Here's another thing that I think happened is that you get this inertia. So if you get less done, then you're going to have just not get tasks done, which causes, where will I put it? I'll just throw it down here. Financial strain, like paying double rent. And having that amount of strain and that amount of worry, I reckon that would just make anybody more depressed. So there's another feedback loop, isn't there? And not only are you kind of, we said that productivity at work is like it causes you worry and anxiety, but it's also caused you to have even some conflict with your manager who you used to get on really well with, and then that's making you more depressed. And it also means that you're more likely to use THC, which means that your productivity is kind of going to get lower. Again, even though you kind of feel like it's the only thing making you feel good, and I get that. So you're going to like, makes you feel great. If it made me feel great, I'd want to do it more. So I get that. But I guess in the spirit of trying to prioritize helping you to feel better and treating the depression, yes, I'm going to ask you to think about what you want to do with the THC. So that's something that we're going to talk about in a minute. Because I guess what these arrows suggest is what are the interventions that make sense? How about we get on and talk about that now?
So, Chris, just there, I've just had a number of questions coming in, just asking about the precipitating factors and if we need more information on them, or if they can be added as well.
I'm really glad you did. I was going to ask you as a group, what's missing? What else would you have done? Why would you start the formulation going, you've got depressed, you're depressed? Well, surely there's going to be 3 arrows up the top kind of going, this would make sense. So yeah, and G might be like wondering that. So for sure, there's always room to do that.
Mm-hmm.
Yeah.
Great.
And I nearly always finish, like the first time I do a formulation, it's a bit like like a session. I often, when I'm writing my notes, I'm like, oh, how did I not ask that? And same with the formulation. So yes, they're really very pertinent question. And you'll see how I deal with that later. There's one more video coming. Yeah.
And JR has asked, I wondered about his social connections, and is gaming keeping him from friends, or does it provide connections? And just whether there's any social anxiety.
Yeah, it sort of pops out, doesn't it? And maybe that would have been something that you asked, and there should be room there to talk about just how limiting that is. That does come out in another go that I have with G. So I'm glad you asked about that. Yeah. Very good questions. These are great. Yeah. Here's the thing. What you can see me doing is pretty much doing is doing a 5P formulation, aren't I? Like I'm thinking, what are the, except for precipitating factors, other than panic attack? Well, there was criticism, but it's not really exploring. But there, you've got the presenting problem, and I've chosen to ignore the panic attack and gone, I think you're depressed. And why would I do that? For the record, I would do that for this session because I just think it's the bigger problem.
Okay.
And if he came back and went, hang on a minute, I can't go back to work because of panic, like, and I'd be like, oh gosh, okay, right, I missed that. I honestly thought the depression was a bigger issue. We need to lean into that. And then I would get a fresh bit of paper and be like, what's going on? Tell me about your anxiety. And we would lean into that. So it's a clinical judgment.
And then Josephine's just asked, which criteria does G meet for depression?
Increased irritability, increased worthlessness, anhedonia, decreased or anergia, and decreased motivation, and feeling miserable all the time.
Thank you.
And cognitive slowing. But that's hard to tell because he's smoking marijuana most nights.
Thanks. And sorry, another question's just come in. Louise has just asked, could you outline what led you to think depression was the greatest issue over panic?
Strength of symptoms and and the level of dysfunction. Because he's kind of stuck at home and is talking about just going, I can't even place an ad to get a flatmate that's costing me, like $450 a week, and I don't have that, and I just can't work out how to do that. And all I just want to do is just stay away from work. I'm like, this guy's on a very fast downhill slope. He's going to get worse within the next 2 to 4 weeks because of the depression. Now, and then I might live to regret that because it's just, well, like I said a minute ago, it just comes down to clinical judgment.
Mm.
And of course, I gave you a 3-slide summary of a vignette rather than a 60 or 70 minutes of me in the room. So these little case stories they're very hard to work with, but they're a useful teaching tool.
Absolutely. And Nicola has asked, would you talk of strength in this formulation?
It's always a really good idea to think about strengths, especially if somebody's depressed, right? Or especially if you've been very problem focused. It's nice to zoom out and talk about strengths. So it's on my checklist, but it's not a have to. It's I'm going to look for an opportunity to do that, and maybe it would come up, and it might not come up in the very first time, the very first articulation of the formulation. It might come up later.
Okay. And then just going back to what you were saying about strength of symptoms, and Louisa said, thank you, that makes a lot of sense. So Helena has asked, you talk about strength of symptoms. In your assessment, are you using any questionnaires to support your thinking?
We're getting onto questions that are moving away from ICFs. But yeah, I'm a fan of questionnaires, sure.
Right.
Alongside clinical interview. I don't use a lot. I mean, to be honest, the DAS is the one I keep at hand all the time. But you got to remember, it's a screening tool, and it's not a fantastic measure of severity of illness in depression. And then you've got other things like the Madras and things like that, which I don't use very often. And maybe others would, but I'm a fan of using questionnaires and different tools for sure. Including even, I do like screening tools, even though they don't measure in depth. But if I'm thinking somebody's probably got GAD, I'll use the sort of 9-item screener.
Thank you.
Yeah. I'm going to go back to my slides. That's all right. I'm going to share them again. And we're still talking about G. So, you're a good clinician, and with your help, G manages to learn about anxiety attacks and test out his fears that they're unlikely to recur, the anxiety attacks. But more importantly, if one does happen again, nothing bad will happen. He's able to actually start to limit his smoking and gaming to Friday and Saturday nights because that made sense. He started to contact friends for interactions in real life. And the rule was, if you're going to do that midweek, you just got to see them. If they're smoking buddies, don't catch up with them. You want to be able to go out for dinner or trivia, or go to somebody's house, or go to the gym, and no substances. He arranges to meet a friend actually before work for a coffee to get him out of the house on time, because he was like, yeah, I'm going to just keep feeling like I'm going to vomit on the way to work. Just if I was late again, I feel like I'm going to get sacked. I can't handle that. It was like, well, what's going to help you to actually turn up on time? It was just accountability. So he said, come on, we'll walk into work and we'll get a coffee and we'll have a catch up. And the friend was happy to help with that. He was also started to notice that his self-critical voice is nastier than he would ever talk to anybody else. So you use the other person test. It's like, would you talk to somebody else like that? He's like, no way. Wow. Gosh, I'm glad you asked that question. I would never talk to anybody like that. I wonder why I talk to myself like that. But he does have another panic attack at work after making a mistake and thinking he would need to share this mistake with his manager. And he left work hastily saying he was sick. He went to bed. He smoked some more cannabis for the first time in weeks and felt unable to attend work the next day. And he had that day to ruminate because he wasn't at work. He just sit at home and ruminate on what an idiot he was and what is he going to do for money now that he's lost his job. And he was telling you, he's flooded with really familiar feelings of self-hatred, shame for being so useless and stupid, and anxiety about having to face his manager. And you're like, wow, this is like different language from what I heard in the first 2 or 3 sessions. So you're kind of going, well, okay, shame, self-hatred, disgust with yourself. Okay, I'm going to give you the YSQ, the Young Schema questionnaire, and you ask some questions, and that confirms that he has long-held defectiveness, shame, and social isolation schemas. In the course of your work with these schema-level core beliefs, you take a more detailed developmental history, and you think to yourself, like me, why didn't I do that earlier? Because I was so busy trying to do my psycho-ed and get this guy out of his sort of free fall. And I was worried about that. That's why I didn't take that proper developmental history. It's a common clinical judgment that clinicians make. And we've got time to do it, but we tend to kind of go, okay, well, I could spend 3 or 4 sessions taking a complete history and I could detail everything. And in the meanwhile, he might actually lose his job because he's decided he's already lost his job. So I might as well not even go to work and talk to my manager. It's like, no, you intervene. Anyway, G said he was the dumbest of 3 children. Both of his sibs did much better at him, in the HSC, one becoming a lawyer, the other one thriving in business consulting. And they both always found reading easy, and he didn't. And the parents praised this, and she seemed a bit embarrassed about his relatively low level of performance academically. You got to remember, he's a university graduate, but in his family, he really was kind of the one who really struggled. Dad, actually, he also said, found him annoying and irritating because he'd often be interrupting things and jumping in, talking too much. And Dad would snap at him with a look of annoyance on his face. And the family teased him for struggling to concentrate or even sit still through board games like Monopoly and Cluedo. So he knows that he's annoying. He knows that he's dumb. You ask a colleague to do a formal assessment of neurocognitive functioning because you're starting to think he's probably got ADD. Was you hypothesizing ADD? Interrupting people, talking a lot, couldn't sit still, had trouble reading. Sounds about right. So you're thinking, well, I don't know, I should rule it out. And that colleague confirms a diagnosis of ADD and excludes ASD. And confirms that he has overall or general IQ is in the above average range. So I've got more info. So I'm going to go and add this to my formulation now. I have to share again.
Gee, we're at that stage again where I think it makes sense to do a bit of a summary. We've been spending the last session or two really understanding how your mood can go from being averagely okay, starting to feel better again, and then absolutely falling off a cliff and feeling terrible. You said that it was like a panic attack, but not like the last one. Huge amount of physiological arousal. You kind of got struck by the the awesome strength of just knowing how useless you were. And recently I've been trying to help you to make sense of that. And I've introduced to you the idea of how we acquire core beliefs, and we soak them in, and they become truths that become a part of our life narrative, how we see ourselves. And, you know, we're also talking about how they're not facts. They feel like facts. They feel undeniable. But you being, you know, dumb and useless and unlikable, that is not a fact. What we've been trying to talk about is how, you know, the square root of 25 is 5. That's a fact. And these are internalized messages. And I think it makes sense to look at it, how this might contribute to your vulnerability for depression. So let's try to write this in a way that kind of makes sense, just based on what we know. So for a start, what I'm going to sort of add is that you were brought up in this high-functioning family, you know, where mum and dad were professionals, and you had 2 sibs that just found schoolwork easy and they worked hard and everybody praised them. But also both parents, especially dad, critical. You know, and we're not here to have a go at your dad or do any parent blaming, but we're just trying to acknowledge the history. And at the same time, what we have now discovered is that you had this undiagnosed ADHD, and you're always chatty, exuberant in your nature. I don't think that's even ADHD. I just think that might be your character. Certainly, sometimes with that ADHD, kids often do blurt things out and interrupt things. It also meant that you found it harder to do academics and sit still and stuff like that. And that combination tended to come together here. And, you know, the language we were using is that you internalized these messages. Do you remember what they were? We said that it was like I'm, you know, inadequate. Nobody will like me. You know, and I'm an embarrassing failure is kind of how dad made you feel over and over again. And mum never corrected that. She was like, yeah, not like your brother, not like your sister. Whew, you know, this is really painful stuff. Like, it's so painful. Nobody can kind of have these feelings and just sit there with them. We always try to do something. We always try to avoid them, hide from them, or sometimes compensate or even overcompensate for them. So that's going to create, if you like, a vulnerability. So I'll draw it as a dotted line to depression. It doesn't make you depressed straight away. It creates a vulnerability. We could also add that if you ever get, and you've told me this, we went looking for it, and whenever you get some feedback or criticism, anything that you find as criticism, when that sort of combines with this, how would we draw that there? It's like a little explosion there, right? that produces a massive, I'm going to call it an activation. And it's an activation of those core beliefs or schemas. And that's like really painful. And then that can definitely contribute to your depression. So we were wondering before, where did this depression come from? We didn't really have anything above here before that. We were looking more at what happens when you're depressed and what maintains it. We looked at how it was understandable that you'd want to get away from bad feelings and even these schema activations, but gaming, maybe smoking. We looked at then how the combination of the depression and your coping strategies meant that you got even less done. Getting less done was more fuel, more fodder for your self-criticism, made you not want to go to work, etc. So it was really hard for you to pull yourself out of depression. You were doing so well until I think you had a schema activation at work. And now we know what that means, that you internalized faulty messages, which are not rational, they're certainly not factual, but they feel true to you. So now we've got some more targets for what the depression treatment is going to look like for you.
There might be some more questions again at this point.
All right, none so far coming through. I'll let you know when they do.
Nice. Still things missing, like as you can see, I think all of these sketches are going to be incomplete, and we just choose what we want to focus on at a time. And as you can tell, I have chosen to sort of highlight the schemas here, the core beliefs, because that's the rationale for the treatment that I'm wanting to convey. And I'm really hoping to increase his self-compassion and dial down his self-criticism. So I'm going to give him some tools and some information at the same time, and some sort of understanding about all of that.
Great. Svetlana's just asked if we will receive a copy of your drawing of G's case formulation, because presumably these videos won't be live in the slides.
That's a great question. I actually, in the slides that I've got for you, I don't include the drawing, so I'll actually put it in.
Thank you.
And then I'll repackage it and send it to Peter.
Thank you so much.
And Lara, and then you'll get it. Yeah. It's not gospel though. Like honestly, if I had to draw it again, it would look a little bit different. You're just kind of just checking to see if it's actually going to help and add some value to the client and serve a purpose. So I'll check in and see if there's questions later. But it's time. Well, we've still got a little bit of time now. It's I want us to consider some variations or atypical ICFs. Actually, first, one thing that came to mind when I was looking back over this is that you can see I'm highlighting very much the perpetuating factors. And I think one of the reasons that I sometimes like just a freeform sketch like this outside of the P boxes that are often up in the corner of a page is that if G saw this and I said to him, look, you've got predisposing factors here in this box, you've got precipitating factors here, and you've got perpetuating factors in the box, it's not quite as strong a connection for me when I just write it out and he sees it emerging. And we get to draw the arrows in together straight away, and it's tight and it's intimate, it's hugging the presenting problem rather than a box in the periphery of a page. So it's just one of the reasons why sometimes I'll go for a freeform diagram like this, which is it's a 5P formulation, but it's just not organized in the boxes the way we sometimes learn it. That's all. So what if G was found actually in that assessment to be autistic rather than an ADHDer? Here's an example. You will get this slide, by the way. It's very similar, right? You've got depression and its symptoms. I have to cope by withdrawing and numbing, THC gaming. I'm going to stay at home and not go to work, but that causes me more problems. My negative thinking tops up my depression. The THC leads to social isolation. Somebody raised that before, and I would highlight that and be like, yeah, you kind of end up, there's a bunch of reasons why you do that. Maybe because you've got decreased motivation and energy. So there should be an arrow coming straight from the symptoms there, and the THC definitely. And the more you socially isolate, the more you're going to end up smoking. And the neurotype stuff here, I'd be like, well, look, on the strength side of things, you've got this beautiful attention to detail. I'd have to be authentic. I have to support it, rather than it being a platitude. Um, you've proven that you can excel in certain areas. Your attention to detail is why you actually are a good project manager, and you can get kind of lost in that a bit. You're so enthusiastic about things that you know and you specialize in. Like, I love that. It's really infectious. You've got this really lovely, strong sense of justice. I like that. We need more justice in the world. But sometimes it can be a bit brittle. And part of the neurotype is that you're actually easily overwhelmed. You kind of need to withdraw and you just go, right, I just need to go home, or I need to cut out, or I need to have a smoke and calm everything down when you're overwhelmed. And you're also not sure how to manage conversations, and you misinterpret what people are thinking. You prefer your routine and everything familiar, and that's why you find yourself really isolated. And then we've got, and you could say this about the ADD too, but like that was never really picked up because you're high functioning and it's kind of mild, but it's there. And I don't blame your family for not kind of getting it because they just loved you and you just grew up there. But I think it was hard for them to understand that it was you had an okay difference from your siblings. It wasn't a bad one. And this criticism and all the comparisons is how you got these internalized messages. So very similar, but again, a slightly different emphasis. We can change it a bit if we've got different data. So you could, if somebody was, autistic, you could chuck it in somewhere like that. And of course, having an autistic neurotype doesn't make you depressed. It's often the interactions with the world around you and not being understood that becomes the problem, or working in a world that is only neurotypical friendly. So if there's one aspect you especially want to highlight, then you might have a separate sketch. I've said that a few times already. This could be to highlight G's anxiety attacks and his hypervigilance for ongoing panic sensations after working mostly on depression. It could be to highlight one level of cognition. So levels of cognition, you've got automatic thoughts, kind of rules that people internalize, core beliefs at a schema level. Then you've got metacognitions. Can I show you a metacognition sketch? This is one I actually did use with a client, and she just had so many automatic thoughts that we just stopped writing them down. There was just this endless stream of like, but what if I did have a heart attack? Oh my gosh. I mean, how would my kids cope? Oh man, if I had a heart attack and died, oh my God, my poor daughter, she would not cope. Oh my God, she'd be in tears. Just imagining how her daughter would be if she'd had a heart attack. And it was just constant all the time. She wanted to move house so she could be closer to Westmead Hospital, live closer to Westmead Hospital. She chose to work at a hospital, and got an admin job there, just in case she had a heart attack during work hours, often going to the GP. So you got a picture of health anxiety. So this is the level of automatic thoughts. Down, I told you I can't draw. Don't laugh. That's the best I can do.
Cute.
Laughing.
It's very cute.
Underlying beliefs where bad things can happen to my family easily, anytime. They were her words. And I'm vulnerable to cardiac problems. She got that belief actually just because her dad had a heart attack when he was like 51 or something like that. And she was now about 40. And her metacognitions are what we really focused on. I'm sorry, this is messy and small because I just wrote it out for her, not for you. But I explained to her, these are your thoughts about your thoughts. So my worry keeps me vigilant, careful, and helps me to pick up on danger and fix it if I need to. It would probably be foolish to ignore this possibility. I mean, like doesn't feel safe to ignore it. If it feels so true, then surely it kind of must be true, mustn't it? I mean, you don't get thoughts and feelings that feel true unless they're true, do you? And my could my I'm so worried all the time. Can I get a heart attack from worrying? Like, can that happen? I think it could happen, can't it? Like, I do get short of breath sometimes when I'm worrying. So pretty typical metacognitions. And they were the focus. So what is this? It's not an ICF, is it? Right? Because it hasn't got all of the features, but it's just one sketch on side of another one where we're zooming in and getting her ready just to try to kind of see as a cognitive therapy tool that the main problem are her underlying beliefs and her thoughts about her worry. I just think that sketching it out sometimes can be helpful in any creative way that you want, as long as it makes sense to the client. So that's a micro little sketch. We're just picking up on one issue, which is the sort of levels of cognition, if you like. So here's another atypical one. Was there a question?
I've just got a few questions. How has asked, since G experienced another panic attack at work, how do we address this within our ICF?
I would, because it was so full, I would probably grab another page and start again and just do a micro. And then if I needed to, I'd bring the two together and go, look, I think you're more likely to have panic attacks because of your depression.
Yeah. Okay.
Or you could insert it, but I would tend to sort of start again.
Okay.
And I'm quite consciously aware that he had another one and it was a problem. I actually, although you might have noticed, I reinterpreted it as a schema activation, not a panic attack.
Yeah.
But that's just it's kind of language. And maybe it was a panic attack.
And then still on G, Vicky has asked, how much weight would you give his protective factors and how would you do this?
Well, as you can tell, when I first did it, this what we'll call the first two iterations, because I've presented it to him, then we've added to it again, and there might be another third and a fourth iteration. It might pop in later. Uh, Perhaps when I would bring it in, not because it's like it's one of the 5 Ps and you've got to have all Ps on the page all at the same time. I would be when it comes to maybe kind of going, look, we really need to build up your existing resources and make them stronger or find them again because you haven't been using them, and we're going to add to them. When I wanted to have that clinical intervention, it makes sense to think about strengths and coping strategies and protective factors. It might be a good idea. Like with some other people, it might be one of the first things that I do, especially if they're like, oh, I'm not coping. I'm like, look, you've got all these coping factors. You've got all these lovely strengths, but I feel like then I'll draw a wall, and I feel like they're blocked at the moment because of whatever. So you could be quite depressed, or you're finding yourself not going out and meeting your friends because you're embarrassed about this disfiguring dermatological condition you've got. So you're just isolating yourself and having time to ruminate. So you have got all these protective factors and you're not using them. So whatever. Like I think there's a number of times and places when you might use it.
Angela has asked, do you have any advice or suggestions for adapting formulations when working with clients who have complex presentations, including clients with partial or limited insight or cognitive impairment?
Well, with complexity, I've already kind of alluded to one of my favorite things that I do is try to look for the underlying common factors. So you're looking for transdiagnostic processes. Like the ones that I've mentioned already include things like low tolerance of distress or negative affect, perfectionism, high levels of self-monitoring, different cognitive styles. Perfectionism is a really well-established transdiagnostic factor. Because if I've got 2 or 3 diagnosable presenting conditions, I want to look at, are they influencing each other, and what are the common derivatives? Is there something down here that's like giving rise to all this stuff up the top?
Mm.
With with somebody with low insight, then it would be developed slower. And I'd be like, this is what I think is going on. I'm going to put this here and this here. Could that be connected? And keep it Socratic. In what way might it be connected? Do you have any data on that? Does it occur at the same time? Does one follow the other? Could we follow that up? Maybe you could. I'm not going to draw that arrow in yet. Over the next week, that would be your self-monitoring, and I'd like you to start to monitor that, and we'll see when that occurs, because I suspect it happens shortly after that, and so forth. And then so we kind of end up doing it together gradually and see if they can build their insight by using the formulation.
Okay, thank you. And Panapong has asked, commented, I really find the way you draw this case formulation very easy to follow. What are your tips when clients do not share about their symptoms and history in ways that are easy to follow and subsequently to draw the ICF diagram?
Oh, then I really struggle and I find it really hard.
Just persist with your assessment.
Yeah, it's a good question. Yeah, just persist. I think Lara's right. Then you go, oh, and then we might keep using all of our assessment tools. We ask for a recent example. We ask for the first time it happened. We ask them to keep not just getting retrospective information, but to keep some prospective monitoring, and some questionnaires and the like. Maybe even get corroborative information from a household member. And then, because you can't do an ICF unless you've got material to put in it. So you're right, it's tricky.
Yeah.
Yeah.
And Svetlana has asked if your book, The Art of CBT, would have a section or chapter that covers micro, macro, and drawing with various cases. Yeah, great.
Yep, does. Amanda's in there, who we looked at before. And there's two other examples in there too.
Okay.
Can I tell you about A? He's a 31-year-old man who presents with OCD. And there's a history of emotional abuse and humiliation by his father when he was a child. And the father was consistently and blatantly favouring an older brother. That brother would receive gifts while A did not. A was shunned while the older brother received attention and praise. And if A complained about this, then his complaints were ridiculed. A learnt to cope by striving to win academic awards at school and then at university, in order to feel good about himself, and hoping, in vain, of course, to get some respect from his father. And while working on the OCD, which is what he was motivated to do, A incidentally said that occasionally he has these rages in which he raises his voice and says things that he knows at the time that he's trying to emotionally destroy the other person. He feels satisfied if they cry. If he feels wronged by them, or even just inconvenienced, if somebody gets in his way, he'll tear them to pieces and stay there until they kind of, cower or cry or something. And he's shocked and regretful, and he wants help understanding why he can be a monster, and he wants strategies to prevent a recurrence of that happening. So this is like one of those learning vignettes where, like, I spent 6 sessions with this guy and I'm giving you 2 slides on him, right? Anyway, I'd explored that history quite a bit. And so I wish to explain the role of humiliation in one's development, especially for males, and the resulting core beliefs and emotional reactivity. And it takes us a while. And I start verbally saying, look, we all have needs. We need to be accepted. We need to be visible and noticed. We need to have our worth affirmed when we're growing up. And when your needs were repeatedly trampled upon, at least 3 things followed. You internalized faulty beliefs that you're inadequate, and also probably that other people close to you will hurt you, so core beliefs about yourself and about others. You became really quite sensitized to injustice and criticism. And the beliefs and bad feelings were so unbearable. It's just awful to feel like your own dad just can't even be bothered to be in your company. He would like walk past you and spend an hour with your brother. And you're like, that is such a bad feeling that it's unbearable. You have You can't sit there with that. You have to defend yourself from that. And then I'd ask him, what are the ways that you learned to protect yourself? And it became automatic. And he was like, yeah, well, I don't know. I just like invested in my work and my career. I wanted all the job titles. I just pushed until I got the best jobs. I wanted people to see my achievements. And I could never, if somebody beat me to something, I just wouldn't turn up to university or whatever. I couldn't, congratulate them for winning a prize in one subject when I'd won a prize in another. And he said, yeah, like I agree that he just cut himself off. And it looked like empathic failure, but it was just numbing, really. And we're able to go, yeah, so you had this literally intolerable humiliation, and the inadequacy feelings were so black inside you. We sketched it as being a black thing, actually, rather than dark green. And so you needed this perfected exterior on the outside in order to be able to function. And it kind of worked, and you thrived. I mean, man, you look at what you achieved at uni, and then and it made you feel good. And you got the jobs, and you got the next job, and that would have made you feel good too. So of course you're going to do it more. But when that perfected exterior was breached, if it's like it's trying to protect you from your bad feelings, and it's trying to make sure nobody else can see your bad feelings, when it gets breached, like somebody criticizes you or gets in your way or holds you up, it's like all that badness, it just comes lashing out, and you've got to do something with it. So there's anger, wanting to hurt back. The self-loathing starts coming out, and then you have to somehow push that back in, and you're going to end up yelling or you'll run away. Because he quit a job at one point, just walked out, spat the dummy, and told them where they could go, and never went back. He found it really helpful. Like it's like it's not, it's a weird, it's like an atypical formulation, isn't it? It's not very cognitive behavioral, but it's more sort of part schema, part developmental. It's the developmental formation of automatic coping strategies. And he was like, okay, that explains a lot. And what it did was gave us the rationale to go in and process what it was like being a kid and do some core belief level work and have some more compassion for himself that he's not a monster. I don't, this is deliberately atypical. And the reason and I don't use these sort of pictures very often, the reason I'm showing you a rare atypical one is because you've already been trained in doing formulations. If it's nice and easy presentation, the way you've learnt at uni will be absolutely adequate. I just wanted to push us and see some atypical presentations and encourage you to be creative and novel in the way you sketch things.
Great.
So does this sketch, meet the usual purposes, like an increased shared understanding, demonstrates empathic attunement from me? Have I been listening? Promoting self-compassion, I think he found it did. It helps the client feel hopeful and directed in terms of those interventions. Has anybody got any thoughts about that picture? Any downsides? What would you add? What's a glaring omission?
JR has said, I love your atypical example. I have a similar but different guy at the moment with terrible early issues. So this will really help, and that there's no omissions.
That's nice. I wasn't fishing for a compliment. That's always good.
No other comments just yet.
We'd better push on because everybody's got to finish pretty soon, right?
Yeah. Oh, sorry. Alex said it may undermine the resilience and growth aspect of trauma.
Thank you. Yeah. And sometimes people might react so we need to be flexible and attuned. The final thing I want to share with you then is what we call a linear model. Judith Beck uses the term linear, and she sort of, when you look at her stuff, like in Basics and Beyond, she'll talk about developmental origins leading to the acquisition of core beliefs, leading to sort of emotional sensitivities, and then she'll just go automatic thoughts, reactions, and then do the ABC model underneath that. What I wanted to show you was something when a client has got a chronic condition or feels really stuck. So this is like G. We're going to go back to G and do a linear one. So it's not deliberately circular. We're not looking for maintaining factors necessarily. We're looking to help a client understand, how did it get this far, for instance. So it's for chronicity. So maybe with somebody with, quite significant agoraphobic avoidance with panic disorder, you'd be like, I think it makes sense. Let's look at sort of all these steps where it came from, and you're ending up right down here and you're thinking, how did I get so disabled socially, or something like that? Anyway, I'll show you G and then we'll finish up. So it starts with him saying, look, you're always prone to worry and self-criticism. You started smoking with friends, found it calming. So then, of course, you started on your own. It wasn't just social. And the more you did it, the more you found it calming. Gradually socializing less and less. And there was also less social and recreational exercise because you stoned a lot. And so you had fewer ways to de-stress and meet your needs. And so you ended up smoking more. And the more you smoked, then you had fewer ways to de-stress or meet your needs. So you smoke more. So there is a maintenance there, but the rest of it's like just a linear line. And then, of course, the more you smoke, is it true to say, I think then you ended up with work and relational difficulties, which means that you got even more upset. So you got upset. So you'd smoke more. So it's quite a different picture. Then I might add, and you're already upset because you're hard on yourself and you worry, but now you're even more upset. So in a way, it does highlight the maintenance or the perpetuating factors, but in a very different way. And so it's just to illustrate this idea that for clients with long chronicity, or that and it's evolved and evolved and evolved, a linear model can help serve the same purpose of compassion, insight, and maybe helping to go, how do we get back out of this? It's pretty much all we've got time for, but I did want to note that ICFs, typically, actually, the way we learn it, they're written. These are really, and I like the idea of writing, in Mantra, the Maudsley anorexia nervosa treatment for adults. One of the most powerful things they do is they write quite a long, it's a standard thing. At about session 6, they write this sort of long thing going, now I've got to know you, I'm ready to do this summary. And it takes quite a while. And they say it's really quite powerful. Other options would be to send a copy of a GP letter to the client, but you would know, you'd have written in there two paragraphs might be, this is my understanding, this is the client's strengths, this is why I think their prognosis is going to be fantastic, and they've got these strengths, and we can understand what's gone wrong. This treatment makes sense, or find some other way to give them a written summary. Anyway, in summary, what we're often trying to achieve is Socratically is light bulb moments for our clients where they go, I've got it right. I can see something now that I couldn't see before. And a formulation and it is a nice way to do that, especially a little like 1 or 2. You could have 3 different individual case formulation sketches that help switch that light bulb on. Have a think about how you learn from these workshops. These it was 2 hours of your life that you've just invested. Have a bit of a think about what you would do it's usually in the next 1 to 2 working weeks, to consolidate your learning. Would you go and redraw ICFs for some of your clients? Would you ask to see your colleagues' ICFs, or take it to supervision and go, I really want to show you my formulation and get your feedback. What would you do with this? And just experiment with different types of formulations. We don't be dogmatic with anything. Find your favorite way of working with things and let your skillfulness evolve. Let me thank again. We're not going to do any small group exercise. AACBT for inviting me in for hosting. And I thank everybody for all their questions. I'll stay online for another, 4 or 5 minutes if there are any more questions.
We have had one question from Tony. It's quite a long question, so I'm just going to summarize it. But he's concerned about the overuse of the word complex in clinical practice and refers to, particularly in compensable and third-party payment systems, that there's a lot of practitioners who are either unwilling or incapable of formulating and conceptualizing their clients, and tend to over-service their clients. So he's just wondering, how can we get practitioners to really do this foundational skill?
Wow. Is that a rhetorical question tonight? How do we do that? I don't know. They should all become members of AACBT. Yeah. Yeah, no, it's great. Yeah, like good insight. You've obviously kind of seen how others practice. I think what your comments, you're preaching to the converted here, and I'm not sure how to answer that.
Yeah, no, look, thank you. And we're getting so many comments coming through just thanking you, Chris. And one that I think is just lovely from Jenny, that she's a uni student, and that this was so helpful and has made it all make sense, which is just music to my ears. So I'm so happy for that. So thank you so much, Chris, for such an engaging and practical session this evening. I think that has been of benefit to so many of us. And, you know, given us some ideas about how we can approach formulation in complex cases, or any of our cases. So thank you to everyone who's joined us tonight and, you know, contributed to the discussion. I love our AACBT community, and just, you know, the way we learn from each other, and, you know, set aside this time for deliberate reflection on our practice. So as I said at the start, this was the first of our 8 sessions with Chris, so the Advanced CBT Skills Masterclass. So I know a lot of people have registered for all 8. For those of you who might have only registered for the one, I hope that might inspire you to come to some or all of the others. So Chris, our next one is in 4 weeks' time, and is, I think, working with low motivation and resistance. So integrating motivational interviewing into CBT, which I'm really looking forward to as well in 4 weeks' time. So on behalf of AACBT and the eBranch committee, just want to say thank you again for your presentation, and thank you to everyone for spending your evening with us. So have a lovely night, and hope to see as many of you as possible in 4 weeks' time.
Thanks for coming, everybody. Thanks for the questions. They were great.
Okay, thank you so much. All right. Thanks, everyone.